I'm going to be speaking about prostate enlargement. Most men will have prostate issues sometime in their life. The ones I see commonly are referred to me because of an elevated PSA, and they're wondering if this is from cancer or just prostate enlargement. The other reason people see me is because they start running to the bathroom a lot. They can't stop when the urine wants to come out. They get up frequently at night to go to the bathroom. They have trouble starting to urinate, which is called hesitancy. They have something called urgency, where you cannot wait. If you don't get to the bathroom in time, you're going to be peeing in your pants. So all these symptoms are indications of prostate trouble. We call it trouble because there's two kinds of prostate problems. One is benign prostatic hypertrophy, what we call BPH. It just means an enlargement of the prostate. The prostate is situated just below the bladder, and the bladder, of course, is connected to the kidneys through a tube called the ureter. The prostate sits in the middle between the bladder and the urethra. So when the bladder is full and you have an urge to urinate, the urine has to bypass the prostate before it comes through the urethra and out through the penis. If you have a prostate enlargement, that simple event of urine passing through from the bladder to the outside becomes a problem. Bigger the prostate, usually the more difficult it is for the urine to get out. But the body compensates by making the bladder wall thicker because now it has to work at a higher pressure, so the bladder muscle will hypertrophy or enlarge. And if you look at my cystoscopy pictures, you can see one patient where the bladder muscle is not that thick, and another patient where the bladder muscle is so thick, and between the muscle fibers you have like little openings that look like little caves. We call that trabeculation and saccules. And this just shows that the bladder is working really hard to get the urine out, and this can happen over years. So the body will compensate by doing that. So the patient may not be very symptomatic or have a problem for a while until the bladder thickness and the pressure is just not enough to get through get the urine out of the bladder. So some patients go to the emergency room because they cannot pee at all. And those patients will end up having a catheter placed in the emergency room, and usually I get a call saying, okay, this patient came to me and we had to put this catheter. Would you mind seeing him? So he ends up in the office later. When I see these patients, I have them fill out a form called a symptom score form, AUA score sheet, which is American Urological Association score sheet. It's a bunch of questions and you mark off some answers. We add up the numbers, and if the numbers add up to about 5 or 6 or 7, we call that mild problem or mild symptoms for the patient. Between 7 and 14 will be medium symptoms or medium problems, and anything more than that, some patients come in and put answer 5s all along those boxes to the right of the questions, and it can add up to 30. So that's pretty severe bother or severely problematic for the patient. And our treatment really depends on how bad the score is, number one. And we also do a urine flow test. We have the patient come to the office with a full bladder, and we have them pee into a funnel which is calibrated, and it actually prints out a graph and it shows the urine flow, and on the X and Y axis you see a flow graph. When you don't have a problem, pressure builds up to about 25-30, and those kind of patients don't come to see me because they don't have a problem. But most of the patients who come to see me have a graph which is sort of erratic, where the bladder is trying to push, and I'll show you an example of that. Or the pressure doesn't build up, so you have the peak pressure is low, the average flow is low, and usually the volume of urine drained is also low, because these patients can't hold too much, so they might go maybe 10 ounces or less, and then they have to go again because they never really emptied the bladder. So we also do a test called a bladder scan, where we have a small ultrasound portable machine, and we just scan it over the bladder and get a reading. It can show a residual volume of maybe 20 cc's, or it could be 1,000 cc's. If it's a big number, then we just go ahead and put a catheter just to get the patient comfortable and then have to deal with the problem. Treatment options, number one, I give the patients a little write-up on prostate enlargement, and it talks about all the different options for treatment. One of the options is just to give them a pill if the patient doesn't mind, or we can always start off with a pill. We usually have samples in the office, so we give them something called Flomax, which is quite commonly used around the country. Other pills as well. There are generic medications now, and there's another new pill called Rapaflo. We use that quite a bit now because samples are available. You give them a trial for a week or two. These pills work right at the bladder neck, where the bladder muscles kind of relax and it opens up the bladder neck and lets the urine flow better. This pill can actually work pretty quickly. In fact, within 2-3 hours, you can see the difference. So if a patient comes to the office and we give him a pill, by the time he goes home, he will notice that he's already urinating better. But usually we give them a week or two worth, and by the time they come back, they tell me if the pill worked or not. If the pill works, chances are the prostate is the problem. If it does not work, it could be that the blockage is a little past the prostate. It could be a stricture where the urethra doesn't have a uniform caliber from the tip of the penis all the way to the prostate. It goes like a tube, and then there's like a kink in the tube. So these patients will obviously not respond because the medicine works higher up, closer to the bladder neck or at the bladder neck. So these patients, I recommend they come in for follow-up with a cystoscopy where we look inside the bladder and identify what the problem is, whether it's in the prostate or the urethra. If the urethra is the problem, then we go ahead and take care of that. It's called a urethrotomy or urethral dilation, where we expand the kink in the urethra, and that can give them relief. And then treatment options also include minimally invasive techniques like heating the prostate, called thermotherapy, meaning heat treatment, which can be done using a radio frequency creating heat or microwave energy coming out through a catheter into the prostate. And these can be done easily in the office with local anesthesia and some pain medications given to the patient before he comes in for the procedure. Procedure takes anywhere from half an hour to an hour total. A lot of these patients can go home without a catheter. These patients, when they come back for a follow-up, say 3 weeks or 4, we again do a AUA score sheet to see if the symptom score has come down. We do a bladder scan to make sure residual volume is lower. We sometimes have them do a urine flow test to see if it's better. And again, I see them in about 3 months and do the same tests, a flow test, bladder scan to see the residual volume. Get them to fill out one of those score sheets to see if the symptom and the bother score is lower. That way we make sure that the patient actually had objective evidence for improvement. Some patients tell me, it really did not do much. And then when they do these scores and check the volumes and the flow rate, we show them, this is before and this is after, it is better. It takes a good 2 to 3 months for the bladder and the prostate to shrink and the bladder to work better, so be patient. Occasionally, there's always a bunch of patients that will not respond to thermotherapy because of the nature of the prostate and the tissue and the muscle fibers and the other tissues within the prostate itself may not respond to heat like most patients. I would say about 8 out of 10 patients do very well. The other 20% will be given an option to undergo a transurethral resection of the prostate, or TURP, and where we get the patient into the operating room, give him anesthesia, go into the bladder, check it out, make sure there's no stones or strictures or obstruction beyond the prostate. And if there is a problem, take care of that. And then go ahead and resect the prostate, where we make a tunnel through the prostatic urethra and take out the tissue manually by suction irrigation. And you can see that in the video. And following that procedure, we normally leave a catheter for a couple of days, then take the catheter out. And these patients see a pretty rapid return to normal function. As soon as the catheter comes out and some of the swelling goes down, they start urinating with a tremendous flow, which is really quite obvious. And a lot of these patients come back and say, man, I wish I did this a long time ago, because they're always scared of having a procedure done where they think they might end up being impotent or incontinent or get strictures or have other problems. Usually there's no such issue after a well-done prostate resection. So, in short, that is how we treat prostate problems. The other prostate problem we see is prostate cancer. And we created a video for newly diagnosed prostate cancer patients, and you can check that on the website under drrajmd.com. And that's a lot of information for newly diagnosed patients.